Welcome to the Johns Hopkins Women's Health Podcast, A Woman's Journey, Insights That Matter. I'm Kelly Gear-Ripken, and I invite you to listen to Johns Hopkins specialists discuss the latest topics in women's health. Now here's your host, Lillie Shockney.
Hi, this is Lillie Shockney from A Woman's Journey at Johns Hopkins, and this is our podcast, Insights That Matter. In this podcast, I am joined by Dr. Julie Paik, Assistant Professor of Medicine and the Director of Clinical Trials at the Johns Hopkins Myositis Center. Today, we are discussing autoimmune disorders in women. So welcome, Dr. Paik, and thank you so much for joining us today.
Thank you so much for having me. It's a great honor and pleasure to be here with you today.
So with over 100 autoimmune diseases affecting 23.5 million Americans, of which nearly 80% of them are women, this seems like information that would be vital for our listeners to hear about. What are autoimmune disorders and when and how do they happen?
Autoimmune disorder is very complex. And even to this day, I feel like as a rheumatologist, we're still figuring things out. But a lot has come so far in terms of research and understanding. But bottom line, an autoimmune disorder is when our own immune system attacks our own body. So I tell my patients, your own body, the natural defense system is not working properly to fight a virus or a bacteria like it would normally do. And instead, it starts to fight your own cells in our own organs. So the organs are thought to be foreign, and then these important inflammatory cells start to attack our skin or lungs or other organs.
What would bring this on?
That's a good question. I think there are a lot of hypotheses of what triggers an autoimmune disease. One is a virus. For example, there has been associations with EBV, like Epstein-Barr virus, can actually trigger disease states like lupus or other autoimmune diseases. There has also been association with cancer, and some of our colleagues in our division of rheumatology is looking into that link, that there's this temporal association with cancer and an autoimmune disease. There's also definitely components of a genetic component. If there's a strong family history of autoimmune disease, you may be more predisposed to developing one.
That's very important to know because a lot of people don't know their family history. With families being so dispersed across the country rather than staying locally in their community, they may not know about Uncle Joe or their grandparents or anything else when it comes to diseases and disorders that a family member may have. I'm always encouraging patients, please maintain a medical history and ask those questions, not just once, but periodically, because over time you may have another family member that ends up diagnosed with one of these disorders. When we look in the environment, could there be some environmental triggers that could cause an autoimmune disorder to come about?
Yes, absolutely. I think there's definitely clear associations with smoking as an environmental toxin. There's clear links with RA, rheumatoid arthritis, and smoking. There's also thought that obesity, although it's not an environmental toxin, eating unhealthy diets can certainly become. They think there might be more storage of fat cells that can contribute to dysregulation and more inflammation in the body. Also, some other, not environmental toxins, but toxins like the drugs we take. Every time I tell my patients, like, what medications are you on? It's like the drugs you give me. So honestly, like the drugs that we give our own patients can consider to be as a toxin. For example, in our own myositis center, it was discovered by the center heads in 2010, and also the lead in our RDRCC translational group in our division, that statins, for example, atorvastatin, Lipitor, can trigger autoimmune muscle disease. And then lastly, this one I've seen, and specifically toxic, actually a true drug, an illegal drug, so to speak, is I've seen cases of this and has been reported in the literature that as a rheumatologist, we should not forget about cocaine-induced vasculitis, which is an autoimmune disease that affects the blood vessels. And it's not actually the cocaine, but the limimazole, which is used to cut the cocaine, can look just like cocaine.
Interesting.
And can actually cause darkening over the ears and cause weird rashes that we can see with vasculitis.
I know when soldiers came back from the Vietnam War, many had been exposed to Agent Orange and developed autoimmune diseases like lupus. So we still need to worry about insecticides and pesticides and other toxins, unfortunately toxins specifically associated with the war and being on the ground as the soldiers and troops unfortunately are. Can you provide us with some names of some autoimmune disorders and point out those that most particularly affect more women than men?
Yes, I think I threw a lot out there, so I'll just try to break it down. I think it's the easiest way to think about these different types of autoimmune disorders is to break it down by which organ or area of the body that it affects. So one of the most common ones that affect the skin, autoimmune disorders that affect the skin or connective tissue diseases are like psoriasis. For example, your own body is attacking your own skin and causes an itchy, scaly rash. And psoriasis can actually affect multiple areas of your entire body, but it can be plaque-like and cause rashes in distinct areas, especially like elbows and knees. And then vitiligo is another skin condition that can cause hypopigmentation. Scleroderma, one of the diseases that I treat, can also cause skin tightness and puffiness. Some other autoimmune diseases beyond the skin would be the joints, like rheumatoid arthritis, and you get a lot of joint stiffness and fatigue and pain. And then, of course, we can't forget about the autoimmune disease that affects our hormones, like thyroid disease and also type 1 diabetes. So I remember having a friend in like high school who had type 1 diabetes when they were like 12 years old. The immune system attacks the cells in the pancreas that make the insulin. And without the insulin, the sugars get really high. And unlike type 2 diabetes, you have to take insulin injections. So, you require the insulin pump and things like this. So there are a lot of different types of autoimmune diseases that I probably didn't list. The other one that I think is maybe more common than one of the other diseases that I treat, like scleroderma, would be inflammatory bowel disease, like ulcerative colitis, where you get bloody diarrhea, and Crohn's disease, where you get inflammation of the lining of the intestines.
Does race or ethnicity play a role in autoimmune disorders?
Yes, absolutely. I think we definitely need more research into this area. Well, we do know that Blacks tend to have more, for example, severe scleroderma when compared to Caucasians. In systemic lupus erythematosus, it's well known that Blacks and Asians tend to have more severe outcomes, including more damage from organ involvement, like kidney disease or brain involvement. So definitely there is clear reports and associations that certain ethnicities and races can have more severe outcomes.
Can you tell us a little bit more about myositis?
Yes. Myositis is basically myo meaning muscle and then itis meaning inflammation. Your own body starts to attack your own muscles, and then you get muscle inflammation and muscle weakness. It's very interesting that there's a distinct pattern to the weakness. Usually our patients with autoimmune muscle disease will always have proximal muscle weakness. So in the upper arms, a shoulder girdle, the neck flexors, hard to lift their neck up out of the bed. And then also the hip girdle. So it's hard to go up a flight of stairs. And there's 4 main different subgroups of myositis. Dermatomyositis, which actually I probably should have mentioned in one of the autoimmune diseases where it can affect the skin, because you can actually get very classic skin rashes over the eyelids that's very purple, over the knuckles. Sometimes dermatologists will see these patients and then refer them to us if it's a little more involved in terms of treatment with immunosuppression. But yes, that's what I deal with. The good news is there's been a lot of developments in terms of treatments in the past few years as well. So it's exciting times in the myositis community.
You had mentioned a few moments ago about drugs like Lipitor. There certainly are a lot of women and men that are taking drugs to try to keep their cholesterol in balance. And I suspect that they're probably not aware that this could be contributing to some other difficulties that they're having with their muscles, whether it be in their hands, making a grip, or elsewhere, as you've just described with myositis. So I just wanted to reiterate that, because I would suspect that some of our listeners either personally have experienced this and didn't know why, or that it could ever been related to a prescription drug, or they're seeing that their husband's complaining about difficulty with doing certain things that affect their muscles that warrants a conversation with the prescribing doctor, because they may need to consider switching perhaps to a different medication that won't carry that side effect, hopefully.
Just to clarify though, because I know statins saves lives and I have friends who are cardiologists, so I do not want people to think we shouldn't take statins. There's definitely two main different side effects. One is the one that I think you're referring to with the statin-induced myopathy, where you can get a lot of muscle pain from statins. And usually when you stop the statin, it goes away within 6 months or even up to a year. But there's also this very small subgroup. I think if you look all across the prevalence, it's very low, 5 to 10%. But I think when we're in the myositis center, we see it all the time. And it was discovered at our myositis center that the statin actually triggers autoimmune process where it attacks your muscle fibers and causes severe muscle weakness in the proximal muscles. So hard to, reach overhead or go up a flight of stairs. It's actually more of a severe presentation than just muscle aches. And when we check labs, the muscle enzymes, the creatine kinase normal would be less than 200, but these patients with this, what we call immune-mediated necrotizing myopathy, or necrotizing myositis, which is one of the subgroups of myositis, they will actually get extremely high muscle enzymes, like CK of 10,000, 50,000.
Oh, gee.
It's a very more severe presentation, but I'm glad you point that out because I've had many patients where they were on this medication for their diabetes because it was protecting their health, and the doctor never checked their muscle enzyme, the CK, and then she got so weak and the CK was 50,000 and she had to be hospitalized. And this is definitely a rare presentation, but I think once you see it more than once, and I've seen many since I've been in practice for almost 13 years now, it's something that you hope that primary care physicians will also know about it and realize it to check muscle enzymes.
Yes, and that's good for our listeners to understand, because if the doctor hasn't done it, they can bring it up to them and say, hey, I listened to this presentation, I listened to this podcast, and it sounds like I need to be having an additional blood test periodically done.
Yes.
Right, which is very important. And sometimes it may require a dosage adjustment of their statin, not coming off of the drug, but adjusting that dosage. So you talked about type 1 diabetes, and there certainly are many, many individuals across the nation dealing with that endocrine disorder, and also talked about rheumatoid arthritis, and we touched also on lupus. Can we talk a little bit about Raynaud's phenomenon?
Yes. I also work in the Johns Hopkins Scleroderma Center. So Raynaud's phenomenon or disease was first described in the 1800s by Maurice Raynaud. We call it phenomenon or attack or episode when we describe it to the patients. But basically, on exposure to cold or stress, any distal organ, so like your fingertips, the tip of the ears or tip of the nose, tip of the toes, in men, they could get erectile dysfunction. So it's not really just only the fingers, but anything extremely distal. So on exposure to cold or stress, you get this intense vasospasm of the blood vessel. And then you get very briefly, hopefully, you get no blood flow to those areas. And then your fingertips turn white. And then when you rewarm them, it turns purple. And then when it's fully warm, it becomes red again. So we always tell our patients that you want to keep your whole body temperature warm and core temperature warm at all times, because cold is definitely number one trigger for that. But one caveat to remember is Raynaud's phenomenon, it can be very common. Like I remember in medical school, I had a friend, a close friend. I was like, why are your fingers turning white when it's raining outside? So that was my first encounter with it. So there is two distinctions in this kind of umbrella of Raynaud's phenomenon. There's primary Raynaud's and then there's secondary Raynaud's. So primary is usually there's no underlying autoimmune disease. Usually you develop it in your teens or 20s and you don't get any digital ulcers, because if you get a prolonged exposure to cold and then you don't get any blood flow, you can get an ulcer. The secondary Raynaud's phenomenon usually happens in patients over age 35. So whenever we have a patient who develops Raynaud's after the age of 35, you probably should talk to your primary care physician and make sure they're doing that secondary workup for Raynaud's, which includes any type of autoimmune disease, but Most commonly, we get worried if it's scleroderma, but not always, because that is the kind of high risk associated with Raynaud's.
So certainly when these individuals are outside in the winter, they must bundle up. They need to have earmuffs. They need to have gloves on that are protective. They need to have boots that are lined with fleece or something.
Yes.
And as well as probably limit the length of time that they're outside as well.
Exactly.
Celiac disease. Let's talk about that for a moment.
I think there's a lot in the media about gluten intolerance versus true celiac disease. Celiac disease is usually diagnosed by blood tests, and ultimately the gold standard is doing a biopsy. But it means that your body is not able to tolerate foods that have gluten, and you can get bloating and diarrhea and constipation. In severe cases, extreme weight loss. So the only way, there's no medication to treat it, but is to completely avoid gluten. I think the US has really done a good job, because I remember going to Brazil like 15 years ago to visit family, and there was a menu for gluten-free, but I think, remember in the US, I think it's maybe didn't take on so quickly, but now I think it's just extremely prevalent. You go to any market. But there is the true celiac disease where it's biopsy proven. And then there's this gluten intolerance, which my patients always ask me all the time. It's like, well, I have rheumatoid arthritis, or I have lupus or scleroderma or psoriatic arthritis. And when I avoid gluten, I feel better. I can't explain that, but there has to be some type of link, I think, with inflammation. And there are some scientists and researchers looking into that gut and autoimmunity link.
You mentioned about doing a biopsy. Exactly what part of the body is biopsied and how is it reached?
So the GI specialist usually will go in and take a biopsy going through to do a biopsy in the intestines with a scope, basically.
Our listeners would be familiar with a colonoscopy, but probably not going the other way as an endoscopy going in through the mouth and down the throat. So I'm just mentioning that because they might be wondering which way is this instrument traveling into my body. Right?
Yeah, that's right. That's right.
Is celiac disease something that could be diagnosed as an incidental finding during a colonoscopy when we're actually looking for polyps to prevent colorectal cancer? Or is that part too low in the GI tract to be able to identify it that way?
Yes, that's a good question. I think to my knowledge, it is too low because when you go from the top, you can reach the terminal ileum. But then when you go from bottom up, it's hard to reach that. So to my knowledge, you want to get to the terminal ileum, which is only accessible through the mouth. Going
through the mouth and down. Yeah, that's what I thought. Yeah, but as I say, some of our listeners are thinking, okay, with my next colonoscopy, I'll say, look for this. The doctor won't be able to get up there high enough in order to do that. Though I'm sure some people think that tube goes all the way up to their tonsils.
Yeah. That's right.
Right. Oh boy.
That's right.
I've also heard of Hashimoto's thyroiditis. Can you talk a little bit about that?
We see a lot of thyroid diseases in conjunction with psoriatic arthritis or lupus and things like this, and even in myositis. But Hashimoto's is when your immune system starts to attack your own thyroid gland and can cause low thyroid levels. And so usually we work with the endocrinologist to see if they need some thyroid supplementation and things like this.
That makes sense. So you're the director of clinical trials at the Johns Hopkins Myositis Center. What clinical trials and as well as what research, including in the lab, are being done here at Johns Hopkins in your areas of expertise?
In myositis, it's been very exciting times for us in terms of clinical trials. The first FDA-approved drug for dermatomyositis was July of 2021, last year, which was the intravenous immunoglobulin. Actually, we knew that it worked for a long time based on the pivotal study done in 1993 by Dr. Delakis, and it was published in the New England Journal of Medicine. So we knew that it worked, but it was only a phase 2 and it was not a large phase 3. And so that's why the FDA never approved it. And so
but you didn't have thousands and thousands and thousands of patients for a phase 3. I'm mentioning that because our listeners may not know the difference between the different phases for clinical trials.
Yes.
So phase 3, there are thousands of people. So you have a large enough study to be able to do pretty deep analysis, which then the FDA can review and go, oh, yeah, this looks good. And I think it does warrant approval.
Right. So for us, though, we'll be lucky if we get several hundreds of patients because our diseases are so rare. They kind of considered like orphan diseases. But yes, you're right, a much bigger population. So it's very exciting because now it's much easier to get this drug that can be life-saving in dermatomyositis, easily approved for our patients. There's so many trials coming up. I'm very heavily involved in trials in our myositis center. There's complement inhibitors and there's other JAK inhibitors potentially that's coming on, which I was involved with as a proof of concept study. I think it's just exciting time.
And so when you say inhibitors, can you provide a definition of that?
Yes. Basically, the thought is that there's specific pathways in dermatomyositis that are upregulated. For example, a specific expression of type 1 interferons, especially in dermatomyositis. And then there are drugs that will dampen that response. Those are the inhibitors that these drugs that I mentioned previously, like JAK inhibitors or complement inhibitors, are thought to work against.
Got it. Are there other areas within Johns Hopkins that are doing research in the autoimmune disease space?
There are many, but one that sticks out is the autoimmune disease research at the Johns Hopkins Institute for Basic Biomedical Sciences. And I think they're trying to understand at a more molecular level to study the cellular, we call machinery of blood cells, like T cells and B cells that are important at the very basic level that drives the inflammation and autoimmunity in these types of diseases or disorders.
What are the risk factors associated with autoimmune diseases? We've talked about a couple of them, but are there some general ones that consumers should be aware of so that they pay more attention to the possibility of being at higher risk for developing an autoimmune disorder?
I do think we talked a lot about it, but one thing I forgot to mention is being female overall is much higher risk. And there's thoughts that maybe it's the hormones or it's the X chromosome. We have two, and there could be more mutations because we have two X chromosomes. I see a lot of patients after pregnancy because, it is kind of like you're carrying. One of my friends like, it's like a parasite you're carrying, like a child, but your hormones are completely,
Yes, they're in overdrive.
Yes. And so after you deliver, it's like your body doesn't know what to do. And so I see a lot of patients after pregnancy too. So when there's these big changes with hormones, so being female for sure, I think the last literature search I did was about 70% of people affected with autoimmune disease are female. And one of the high risk groups would be like in lupus, they think it's like 3-to-1. We know that even in scleroderma, it could be 2-to-1, 2 times higher than more females. MS also is higher risk in females. And then we talk about family history and the genetics and some of these other exposures that we can control, hopefully, is like smoking and exposure to toxic agents.
And for smoking, does that include secondary smoke?
That's an excellent question. I don't know that anybody has looked at that in a rigorous fashion in a research study, but I would think that there could definitely be that, depending on how the severity, it certainly can contribute. Because recently we had a patient in our pulmonary lung conference, because I'm in the scleroderma center and scleroderma patients can get a lot of lung disease. And, she was so short of breath, reviewing her very complex case. And when we looked at her CT scan, we're like, oh, it doesn't look like the scleroderma, this autoimmune disease is affecting her lungs. Like the CT scan actually looked really good. But when we looked at her background, she was from Mongolia, which we know, and there's been papers on this, how because they live in high elevation and the way they cook, there's just so much toxins with the cooking and the air.
Oh my, that's worrisome.
Yeah, that was interesting. Yeah.
Wow.
So anyway, point of that was just that secondhand smoke or other toxins can potentially contribute.
You mentioned towards the beginning of our discussion about cancer. We know that cancer requires, as part of its foundation to be able to even get itself established, that there needs to be inflammation in the body. And that could be, for lung cancer, inflammation of the lungs irritated by this smoke that contains some toxins. We look at melanoma, we're looking at inflammation of the skin from severe sunburns commonly. So it makes sense to me that there would be a correlation or a potential one looking at some cancers, and also its linkage with possibly setting you up for autoimmune disorders and vice versa. But I'm curious to know, are there other comorbidities like heart disease that would set that individual up for potentially getting certain kinds of autoimmune disorders in the future?
I know that there's a lot of evidence in the literature that patients with rheumatoid arthritis or lupus, especially those two diseases especially, they have this chronic state of inflammation, like you said. There are very nice studies showing that there's higher risk of cardiovascular events like MI or other cardiac comorbidities like hyperlipidemia or high cholesterol and things like that. So it is our goal as rheumatologists to aggressively control the inflammation so that we're not dealing with complications that can lead to cardiovascular events. But that's the most evidence in RA and lupus. We haven't seen that so much across, because I do a lot of myositis and scleroderma. It hasn't really played out all across all these different types of autoimmune diseases. The most common is that high risk association is really in RA and lupus.
Well, I've certainly learned a lot. I'm very confident that our listeners have as well. So thank you so much, Dr. Paik, for joining us today and sharing with us this very important information, which I know is going to make a positive difference in the women listening today, because they're not only going to apply this to themselves, they're going to apply this to their family members as well. So it's sort of like you help that first domino in the row to fall over. Our listeners are going to let the rest of that domino row fall. So you will have reached far more people than you ever will know. Thank you for doing that.
Thank you so much for having me. It was a great discussion, and happy to be here.
Thank you for listening to A Woman's Journey podcast. Join me, Kelly Gear-Ripken, your host, Lillie Shockney, and a variety of Johns Hopkins experts on the first Thursday of each month to learn about medical advances in women's health. A Woman's Journey is grateful for the unrestricted educational grants from HRH Foundation that supports our podcast series, Insights That Matter. For more information about A Woman's Journey's virtual programs occurring throughout the year and our monthly webcasts and podcasts, visit our website, hopkinsmedicine.org/awomansjourney. Like us on Facebook and Twitter, and visit our website at hopkinsmedicine.org/awomansjourney. Until next time, stay well.